Stage 1 is the first 3 years, and
Yes.
then after that is stage 2. So what's the process like for applying into stage 2?
People will apply. We're not envisaging that people are going to do pure internal medicine. People do not do pure gym now, so we don't see any change expected for that. We hope that the vast majority of specialties, certainly the biggest ones, all trainees will do internal medicine and the specialty. So they will be applying to do internal medicine and the specialty. And like now, their training program director in the deaneries or in the Let B will have to, what we call curriculum mapping, they'll have to plan how they're going to achieve all the competencies, both completing internal medicine over the 4 years and completing their specialty training in their chosen specialty. We envisage that there are going to be two groups. That one, the biggest group by far, will be those that will continue to do all aspects of internal medicine, all aspects of acute take. And those at the end will come out with a dual CCT in internal medicine and their specialty. There will be some other specialties, for instance like clinical genetics, as an example, or rehabilitation medicine, when there will be aspects of internal medicine that don't involve acute care. But of the 14 incompetencies in practice, 11 are highly generic and probably refer to almost all specialties, and they will contain the generic professional capabilities. So people will still have to follow the internal medicine curriculum for those 10 or 11 competencies in practice. It is just at the end of training that they will only receive a single CCT.
And will that mean that some specialties then have less time if they're committing the first 3 years to internal medicine instead of 2? Will they have less time after from where they now have ST3 to ST7? Some might then have from ST4 to ST7.
For most things, it's about 7 years. So currently 2 years core medical training, 5 to do dual training. In the new model, it'll be 3 years of internal medicine, then 4 while they complete the 4th year. It is possible that some specialties that currently only do 4 years of training and do single training, if they choose to take people after 3 years of internal medicine, I think most will, it could be perceived that they are potentially getting an extra year of training. But that is very much a minority. And we have to accept now that there is very considerable flexibility.
Can you kind of clarify for the trainees that concern about sub-consultant level and credentialing?
People have said to myself and to the colleges, well, what we want is a general physician. And that's all. And couldn't you train that in a shorter length of time? Which might be how shape of training, well, one of the suggestions. Well, I point out to them that we currently have a general internal medicine curriculum, which is only 5 years long, and which sits on my shelf there, and not a single dean wants to appoint any trainees in. So currently there is no wish in the system to appoint such a person with such a length of training that might in some way be considered a sub-consultant grade. We believe that the doctors we're producing who are dual trained are going to be fit for purpose as consultants, and there is no suggestion in our plans about producing a sub-consultant grade.
And credentialing?
The GMC have made decisions in the past that credentialing should happen, but there is still no clear way forward for that. Nor importantly, is there any way of really understanding how it is to be funded, because credentialing as proposed by the GMC is going to be quite complex. We are going to have to design quite specialist curricula. We're going to have to meet the same standards for credentialing curricula as we do for normal curricula, and that takes a lot of time and effort. So if it's only going to be for a very small number of doctors, then it's going to be quite expensive. and it isn't clear at all where that expense would be met. And certainly I'm absolutely certain that if that was suggested as having to come out of trainees' salaries, then there would be tremendous resistance. We've offered post-CCT fellowships, which are much simpler, more straightforward, and some specialties, particularly the cardiologists and the dermatologists, have found that actually is that informal structure which treats people who have come off the CCT as senior doctors with educational guides, not with supervisors, is a model that has worked quite well for helping people develop particular areas of interest after they've completed generalist training. And it is possible that we'll end up expanding that again, maybe keeping credentials for particularly important niche areas.